screening, diagnosis, how to manage, and complications. And I just want to touch on one of the major complications before I conclude. So historically, obesity was at times associated with wealth or prosperity in certain societies, reflecting abundance and limited manual labor. So as you can see in this picture, there is a tribe in Ethiopia called the Odi tribe, where it is considered the bigger you are, the more attracted one is. And I can say that that is quite true for other communities, true worldwide. However, in the mid-20th century, the WHO had actually noticed the global pandemic and named it as it. So it was coined that the global pandemic of obesity was named globicity in 1997. And this was secondary to the global food production and consumption alongside the increased sedentary lifestyles. Today in South Africa, 70% of females and 30% or 40% of males are considered either overweight or obese. And it's predicted in the year 2030, 1 in 3 South Africans will be obese. So now let's move on from the pandemic and focus more on something that I actually truly am passionate about, and that is pregnant ladies. So 4 years ago, in 2021, it was reported that 21 million pregnancies worldwide was complicated with hyperglycemia. That means 16% of the world's population, of which 80% was classified as gestational diabetic. And that just reflected the rapidly worsening global obesity pandemic. The South African stats reflect, however, I actually do believe that it has worsened in the last 4 years, that the prevalence of hyperglycemia in South Africa was ranging about 10 to 15%. This not only complicates pregnancies itself, but it also burdens other complications such as preeclampsia, preterm labor. It increases the risk of cesarean section in pregnant ladies. And not only does it complicate mothers, but it also complicates the future generation, because gestational diabetes has an effect on the future generation in terms of long-term complications of those children born to moms with this disease. So it is crucial to say prompt diagnosis and adequate facility care is essential to ensure safety to both mother and baby. And of course, with the global rise in obesity, GDM has been deemed a health challenge. So now we know that there is a problem. Now, what do we do about it? Like, how do we go about deciding who is going to be affected with gestational diabetes in pregnancy? So I thought this is how we could go through it, a stepwise approach onto seeing who should we target, how should we target, and when should we target them. So let's start with the easy one. Who should we target? So there are 2 ways of screening, or 2 methods of targeting these individuals. So one is the universal screening, and the other is the selective risk-based screening. So the selective risk-based screening is it's more cost beneficial, and we use this for screening populations. So let's talk about it. Now, it identifies patients who are at higher risk for actually developing gestational diabetes. So this is risk factor based, and one or more risk factors will deem you will deem you as high risk. And once you're deemed as high risk, you are then further objected to a screening program or a screening method, and that will be discussed further. So let's talk about the history-based screening. It is a history of gestational diabetes or gestational diabetes in your previous pregnancy, a previous history of macrosomia, history of obese, if you're obese of more than 30 kilograms by meter squared, if you have a first degree relative as a mother or a sister who's had diabetes, you're deemed high risk. High risk ethnicity, so this is Southeast Asians, Middle Eastern patients, as well as African females are all deemed as high risk ethnicity. And Southeast Asians on that, they don't even need to have a BMI of more than 30. A BMI of 23, which is normally deemed as normal, is already deemed as high risk. So they're deemed as high risk irrespective of their BMI. Then if patients have complications of other metabolic diseases such as hypertension, or other metabolic diseases such as thyroid, they're also considered high risk. A previous unexplained intrauterine demise in your second or third trimester. Glycosuria of more than 2+ on one occasion or 1+ on 2 or more occasions. And an advanced maternal age of more than 40. Patients who are on chronic use of corticosteroids or prior infants who are born with congenital abnormalities. So if you have one or more of these risk factors, then you are deemed to a screening technique at 24 to 28 weeks. And then if you have more than 2 risk factors, you can actually be screened at an earlier stage, i.e. your first visit. But if you have a history of gestational diabetes, you're already classified as high risk, and you can be screened at your first visit already. So we know that we can screen patients. So why do we screen at 24 to 28 weeks? So pathophysiology dictates that the overgrowing placenta rapidly starts increasing their production of hormones such as human placental lactogen, your cortisol, your placental growth hormone, which all collectively progress your insulin resistance. And that is only to physiologically improve the glucose or to increase the glucose in the maternal circulation for the ever-growing fetus. So screening early misses females who have not reached their peak insulin resistance, while screening them later on, unfortunately, already delays the diagnosis and increased risk of complications that have already set in. So 24 to 28 weeks seems to be a good balance to actually look for gestational diabetes. Okay, so we know who and we know when. Now, how do we screen? So there are different methods of screening. And let's talk about the world, and then we will get back to our own South Africa. So let's talk about the universal testing. So in USA, because USA has got an obesity problem, firstly, and because they've got unlimited resources, more resources than us for sure. They do the universal testing. So irregardless of history based, they will screen you. They screen according to a 2-step Carpenter-Kustan criteria. And this actually starts with a screening test. So when a patient comes through to you, you will screen them for gestational diabetes, irregardless of time of the day. You give them a 50-gram oral glucose solution, and then you measure a serum or venous plasma after 1 hour. So if the reading is more than 7.2 millimoles per liter, then they're subjected. So then they're screened as positive. So a red flag gets ticked. So now they are subjected to further testing, which is a 3-hour glucose challenge test. So here they're subjected to drinking 100-gram of glucose solution, and then they are tested at every hour. So the first hour after given the solution, the second hour, and then the third hour. So if you have 2 or more abnormal readings, you are deemed as gestational diabetic. So that is how the USA does it. Now moving on to country a little bit closer to home, and that is the UK. The UK follows the NICE guidelines, and they do a similar screening as South Africa. So their screening is risk-based. So they do selective risk-based screening, which is what we had already gone through. So patients with risk factors are deemed as high risk, and then they will be given the 75-gram OGTT, unlike the 100-gram OGTT in the USA. Just a caveat, just like us, or just as it says, that if you have a previous history of a gestational diabetic pregnancy, you can have the screen test. You don't need to wait 24 to 28 weeks. You can be screened as early as first trimester. So these patients are subjected to fasting for about at least 8 hours. They can drink water, and then they come early in the morning on their while fasting, and then we test their venous sample, and then we subject them to a 75 grams glucose in 250 to 300 ml of water. It's a very strong solution. And then 2 venous samples are taken. It's just one venous sample is taken at 2 hours post-ingestion. So if you have a fasting plasma of more than 5.6 millimoles per liter, or your 2-hour plasma glucose readings are more than 7.8, you are diagnosed as gestational diabetic in pregnancy, right? Okay. So now we've done the USA, and we have done the UK. Now let's move back to home ground. So I think this is the only time when Australia and South Africa actually agree on something, and that is screening for diabetes. And we are backed up by the International Association of Diabetes and Pregnancy Study Group. So we subject our patients to a 75-gram OGTT, just like the UK. So very similarly, the first thing we do is we do a risk profile. We screen patients. If they're screened as high risk, we will subject them to 75 grams OGTT. And the only difference that we have with the UK is that we actually follow the International Association of Diabetes and Pregnancy Study Groups, which is IADPSG values. And SASAG has agreed with us with that. And these are the values. So once a patient has fasted the 8 hours, we do a fasting glucose, and then we subject them to the 75 grams of glucose solution. And 1 hour after, we do venous sampling, and then this 2 hours after ingestion, we do another venous sampling. So we've got 3 values in South Africa. And if any of the values are above 5.1 for fasting, 10 millimoles per liter in 1 hour or 2 hours, 8.5 millimoles per liter. If any of these values are deemed abnormal, you are diagnosed as having gestational diabetes. So now we have decided, we have diagnosed you, we have screened you, we have diagnosed you with gestational diabetes. Now what? And I think this is the important part, because I feel counseling is so important and so vital, because their entire pregnancy now has changed. And I'll take you through the steps. So counseling involves a lot of discussions, but I think the 4 main topics, or the way it is divided in the picture on the right, helps us, or helps me for sure, break down what counseling entails. So we start with counseling about maternal education. And we start with maternal education, and I normally start with 30% of patients require medical therapy. And the reason I start with that is because there is data to support that. There is a US Preventative Service Task Force that has done randomized a meta-analysis on randomized controlled trials, which showed that patients who are on medication versus not on medication are complicated. So their pregnancies are more complicated. So patients who are on medication, there is a decrease about 1.3% of newborn injuries. There is about decrease about 8.9% of macrosomia for these patients. There's a decrease of more than 2% of NICU stays of these babies born to these moms on treatment. And also these moms have a decreased risk of preeclampsia and preterm birth when they're on treatment versus not. And also, just to motivate them on how to actually continue with their regime until they are postpartum. So yeah, counseling is very important. Now, let's talk about nutritional counseling. So nutritional intake goes a long way, and it emphasizes what we say: you are what you eat. So I'm very lucky to have dietitians in my practice. So I normally refer my gestational diabetic patients to the dietitians to assist with their nutritional intake. But in case that some of you do not have that luxury, or your dietitians are already overburdened by the many number of gestational diabetic patients that they get, maybe some simple steps will assist you in counseling these patients. So the first thing that I always tell them is that one needs to start eating 3 small moderate-sized meals with 4 snacks. The snacks involve either a vegetable or a fruit or nuts, for example, and not actually a sandwich. Then cutting out or decreasing their sugar intake as well as their junk food intake. I think that already takes off about 30 to 40% of my patients' problems. Then to get into details is where we need a nutritionist or a dietitian to assist us, because then we go into the nitty-gritty details of how much calories that we advise them in each trimester. So for example, in the second trimester, we would advise them to only have about 340 caloric intake per day, and then that increases to only about 425 calories in the third trimester. So the nutritionals or dietitians are vital to assist in just nitpicking on what does that entail. And then also just to talk about in terms of a plate, just a portion of carbohydrate, protein, and fat, just to give them an idea of how much of each you should be eating, or what portion of a plate that each food item should contain. And also there was a 2005 study by Carpenter and Custone, which actually states that 85% of these patients, just by achieving a good nutritional intake, will actually allow them to continue that and not need medication for controlling their diabetes. Okay, the next is lifestyle. So it's a lifestyle change from a sedentary lifestyle to a more active lifestyle. And what do we mean by that? So there have been RCTs and ACOG, or American College of Obstetrics and Gynaes, advise patients to do at least about 30 to 60 minutes of aerobic exercise every single day. And what that means, or what that entails, is either walking very fast, or jogging if a patient can do that, or walking up and down the stairs. The other thing that is really good for you is swimming, and also cycling, but not cycling in streets, but on a fixed cycle. The only activities that we don't advise our pregnant ladies to partake in are contact sports, such as boxing or kickboxing. The second is also, we don't want them to be lifting any heavy weights unless you're used to. So those are the only two areas. And then there's also another study that was done in 2016 by the physiotherapy team, which had stated that just by exercising, we can already decrease the amount of insulin required, as well as our postprandial glucose, or HGT, levels. So just lifestyle, exercising, and nutrition can go such a long way. Okay. Then once we have discussed nutrition and exercise, then we need to actually give them goals, because I think patients are goal-orientated, or well, I believe they are, and giving them set targets assists in their journey. And so I always say, so weight gain during a pregnancy, and that's very important. So for example, if a patient is deemed overweight or obese, you're only allowed for the whole period of 9 months to increase your weight from 9 to 11.5 kgs in total. So for example, patients already come to me in their first trimester and they've already picked up 5 kgs. And if they're obese, I have to tell them that they're only allowed 4 kgs. And they're already quite surprised, because they're like, are we allowed to lose weight in pregnancy? And I'm like, yes, you are. You're allowed to lose weight, and just try and maintain your exercise and nutritional status, or increase your exercise and decrease your caloric intake, and then we'll get to our end goal. So it's always a team effort. Okay, so then we talk about monitoring your HGTs. So once a patient is diagnosed with GDM, they are always given a glucometer. They're giving your needles, your strips, and your cotton, and then they're given a 6-point profile to monitor their HGTs. They're told normally to follow up about in a week to try and see how their glycemic profile has been for the week. And then these are the targets that we try and look for. So we monitor our patients using a 6-point profile. So they're given a piece of paper where they are asked to check their sugar sugars preprandial. So that's morning, breakfast, lunch, and supper. So they're advised to check just before they eat, and then an hour post their meal, they check again. So that is why there are 6 values to look for. And the targets that we use is your preprandial HETs should be about 5.3, and your postprandial should be about 7.8. It's places like the USA or even other places in the UK, they use 2 hours. So it depends on where you are. Either way, you just need to know your target values. So a lot of patients and a lot of colleagues have asked me, is there a value of using an HbA1c to monitor your HETs, I guess? And it's a yes and a no. The yes only comes in because if your HETs or your HbA1c is very high, I can risk stratify you to say that you are at a higher risk of getting or of congenital abnormalities. But it doesn't really tell me about your glycemic index for the last 3 months like it does in a non-pregnant lady. And that is because the blood glucose concentrations in a pregnant patient is about 20% lower than normal. So it's not a very good marker for glycemic profile. And some patients, the second question that a lot of patients or colleagues ask me is that, can the frequency of the 6-point profile be reduced? So for example, once you're diagnosed, for example, at 24 weeks, some say that you have to be on a 6-point profile up until you're 9 months after, until you deliver. And that is very subjective. And I think it should be a senior who decides this, because one, you need to have a good rapport with the patient to understand that she is checking the values and not crooking the values. One, two, that there is also that there is no sign of fetal complications. So the fetus is not growing above the 90th centile in terms of weight, and the abdominal circumference is not going above the 75th centile, which both shows that the baby is growing bigger and that is secondary to a poor glycemic control, and as well as normal amniotic fluid. So if all of these criteria are checked, you can actually try and reduce the number of times and frequencies that they are pricking themselves. Okay, so now you've diagnosed them. They know how to check their 6-point profiles. Now what? How do you manage them globally in their pregnancy? And for us, it's more trimester based. So in the first and second trimester, they should adhere to the Bank Plus guided checkups. So every 4 weekly or 2 weekly checkups according to their trimester. They should be referred to a tertiary center or regional hospital where appropriate level monitoring is taken care of. One needs to always ensure that baseline bloods are done to verify their organ function and to ensure that there is no organ dysfunction as the pregnancy progresses. Example, your renal functions, just to ensure that there's no end organ target damage. And then patients have to have at least level 2 or level 3 scans to rule out congenital anomalies as well as growth abnormalities. It should be ideally in a center where they can actually accommodate a multidisciplinary team with a dietitian, with the maternal medicine subspecialist. And if the sugars are very poorly controlled, then we would also ask the help of our physicians, the endocrinologist input as well. Now, in the third trimester, because there's an increased risk of an intrauterine demise, we start doing non-stress testing from 32 weeks. And we start scans, we continue our scans, and we provide scans at 32 weeks and 36 weeks. And this is just to monitor the growth of the baby, especially. And then you continue the antenatal follow-up every 2 weeks until 36 weeks, and then it's every week. And then this is also a time that we also start discussing mode of delivery and when. Remember that mode of delivery and when to deliver should not be a discussion only in the 3rd trimester. This has to be this discussion has to start from 1st trimester, 2nd trimester. For example, a previous Caesar ×1. You need to get that history even in your 1st trimester. So you are having a discussion, an ongoing discussion with the patient on her birthing plan. So just to show you that in 2023, January, there was a diabetic care guideline that actually already showed the benefit of just having appropriate care. So they said there was a 32 randomized controlled trials that was evaluating the effectiveness of just telehealth visits for GDM patients. And this alone decreased the risk of cesarean deliveries, neonatal hypoglycemias, premature rupture of membranes, macrosomia, and pregnancy-induced hypertension, as well as preeclampsia. So just by getting adequate care, we have already reduced the risk of or decreased the risk of neonatal and maternal morbidity and mortality. Okay. So now, once we have diagnosed, what kind of treatment should a patient get once they need treatment? So we know that 30%, as I said from the beginning, 30% of gestational diabetic patients will need pharmacotherapy. So once treatment is needed, how do you choose the treatment? Should it be oral treatment versus an insulin treatment? Because remember, patients are also very apprehensive to actually inject themselves. So we need to decide, or we need to give them the right understanding on why we choose the medications that we choose. So they had a randomized control trial in American College of Obs and Gynes, as well as the Society of Maternal Fetal Medicine. Guidelines have stated that they did a randomized control trial between metformin and glyburide versus insulin. So this is oral treatment versus insulin. And they actually said that both of them were actually comparable. So not one was inferior than the other. And they did not one of them actually reduce the reduction of infants born with large for gestational age. So it depends on your 6-point profiles. So if your 6-point profiles are not being controlled on an oral agent, then we need to decide on going into the insulin regime. So if their 6-point profile does not look too bad, what medication in terms of oral medication is better? Is it metformin versus glyburide? So they've actually stated this, they've actually come to a conclusion that metformin has a better perinatal outcome. So we would rather, and we also have long-term data on metformin versus glyburide. So we do recommend metformin if you had to go the oral way. Okay. Now to the insulin. How do we choose, and what are the dosages that we need to think of? So there are 2 types of insulins that we use in gestational diabetes. We use the long-acting and the short-acting ones. And how do we decide on how much dose that they need? So for example, if you have an outpatient clinic and you've got a patient in front of you who you've got the values of your OGTT and you know that one of the values is abnormal and you have just counseled her and you've said that you've got gestational diabetes. Now, how much of insulin is required for these patients? So then there is a formula which is trimester based. There are actually two ways of doing it. Let me explain the first way. The first way is to do the trimester-based formula, where you use either 0.6 units to about 1 unit per kg per day. So for example, I've given an example on this side. If you have a 65 kg female and she's in a second trimester, you can choose to say, you can say 0.7 units. And you multiply that with, sorry, I used 60, I realized. So you say by 60, and you get the total insulin needed, which is 42 units. Now, step 2 would be using your 2/3, 1/3 rule, which is 66% of your total dose is given during the meals. And how we calculate that is by doing 2/3 of the total 42 units, which you'll get as 28 units. So that is the 28 units that you require during the day. And you further divide it into 3 and you get 8 units. And 8 units is what you give the patient postprandial. So that is half of it. So this is short-acting insulin. And then the 1/3 that we get from the, so 1/3 of 42, which will be 12 units, is what we prescribe as long-acting, and that is the protophane that we can give. I hope everyone is with me. We can go through it if you don't understand. But that is the calculation of how much you can give, how much insulin to give. Okay, the second method is more for inpatients. So for example, a patient has been in your unit for a full day and you have been, and the patient has had a sliding scale the full 24 hours. Now, you do the same 2/3, 1/3 rule after the 24 hours. So you just need to calculate how much insulin that this patient needed for the last 24 hours. And then you divide it into 2/3 and 1/3. So 2/3 of the total and 1/3 of the total. The 2/3 of the total is the actrapid that you will give, because you're going to get that value and further divide it into 3. And then the 1/3 is the protophane, which is long acting. I just went on to explaining. It's the same way as we did the previous. It's just that there are 2 ways of calculating it, depending on if it's an outpatient or an inpatient. Okay. So now we've got continuous insulin analogs, which are small wearable devices that delivers continuous basal rates of insulin. There are advantages and disadvantages. Unfortunately, this is very expensive. So it hasn't been available to our state sector patients, but I am sure that I know my endocrinologist colleagues are already starting to use it on their type 1 diabetic patients. So once they reach their reproductive age, I'm sure that I will see more of this. But I'm sure in a private setting, this is something that is becoming quite common. So they're both advantages and disadvantages. So the advantages is that it is shown to improve glycemic control, because the pump allows like fine tuning of basal insulin in real time, as well as it is flexible during your meal times and depending on what you're actually eating. The second advantage is that it reduces severe hypoglycemia. So for example, for the night So for example, pumps can lower basal insulin rates overnight, potentially reducing nocturnal hypoglycemia, and especially in patients who are very active, the pump is very good in terms of fine-tuning the amount of insulin that you need. And then the second and the third, which I think is very pleasing to someone, is that the quality of life that you get from a continuous insulin analog, that they've got a greater dietary flexibility and an improved sense of control because you're not there physically taking out the amount of insulin that you need or even injecting that amount. This pump is already doing it for you. The disadvantage, as I said, the major disadvantage is the cost and availability, unfortunately. So as I said, it's only mostly available for the private patients at this point, and in state hospitals, it's reserved for the type 1 diabetics or brittle. There's always training needed regarding wear and tear. So patients have to be continuously educated on how to wear it, how to use it, and how to monitor. And then also patients find it very uncomfortable or challenging because as the abdomen grows, it is hard to decide on where to place it. And then of course there's the grave disadvantage that is the risk of diabetic ketoacidosis in case that this wearable device has a malfunction. So people who are wearing this just needs to be trained and alerted to looking for signs and symptoms of complications. Just in terms of evidence for this, we know practically how the advantages and disadvantages, but there is evidence on pregnancy outcomes. So there was an observational data which showed that there's a slightly lower rate of macrosomia in pump users versus the meter-dosed insulin pumps. But there was no conclusion in terms of, or there was no evidence that it was a better system when it came to complications of maternal preeclampsia and hypoglycemia and cesarean rates, section rates, as compared to normal insulin technique. But always remember that you need to select your patients, because ideally this is for pre-gestational diabetic patients, as I said, type 1, or patients who are gestational or deemed to have gestational diabetes, but also have are need of like very much higher doses of insulin. So this is a good time to actually motivate for such a device. And then obviously remember the cost benefit analysis when you are thinking of ordering this machine. So these are just the data in terms of backing up all the things that we have said. So just moving on to complications. When we talk about complications in a gestational diabetic patient, you have to talk about both. Remember, we deal with both the mom and the baby. So the biggest complication that we deal with is fetal demise. And then obviously fetal anomalies. The major fetal anomaly that we have is sacral agenesis, and then your cardiac abnormalities such as AVSDs. These patients are also at a higher risk of spontaneous abortions, macrosomia, neonatal hypoglycemia once they are born, neonatal respiratory distress syndromes, and increased risk of NICU stay. And then because of the epigenetics that they are exposed to in utero, there have been studies which have shown that patients or babies who are born to mothers with gestational diabetes further in life go on to have type 2 diabetes, and as well as metabolic syndromes later on in their lives. So that is from a fetal point of view. And then in terms of a maternal point of view, there's an increased risk of hypoglycemia, preeclampsia, diabetic ketoacidosis, prolonged hospital stays, just to get their sugars under control. And 50% of gestational diabetic moms go on to actually having type 2 diabetes in 5 to 10 years. So this already increases their cardiovascular risk as well. So that is why it's essential to actually screen for such patients. And just before I finish up, I wanted to just discuss the diabetic ketoacidosis, as it is a maternal complication and it is a medical obstetric emergency. So it can result in a life-threatening fetal hypoxemia and acidosis, as well as increased maternal mortality and morbidity. So the prevalence is about 0.5 to 3%. And the pathophysiology behind diabetic ketoacidosis is secondary to the relative insulin deficiency because of the ongoing increasing placental hormones, such as your growth hormones and catecholamines and glucagon. So these pregnant individuals are always prone to a state of ketosis because of their metabolic changes. And there's always something that will trigger this response. So there'll be an underlying cause that actually leads them to this metabolic change and leads them to diabetic ketoacidosis. So normally these patients, they present with gastrointestinal symptoms such as nausea, vomiting, abdominal discomfort, low abdominal pain, polyuria, polydipsia. And if severe, they also have altered mental status. And once you have a diabetic patient with these symptoms, you need to first try and do a blood gas if you have, or take bloods to send to the lab immediately. And what we're looking for is a pH that is acidotic. So a pH ranging of less than 7.2, an elevated anion gap, and a low serum bicarb of less than 18, ketones in the urine of about more than 2+, and the hyperglycemia can be normal in pregnancy, so you shouldn't actually always look at the HET to say that they are in diabetic ketoacidosis. So once you have a patient with these symptoms and then you have a blood gas or lab findings of the ones that I mentioned, then you can diagnose these patients or suspect these patients to be in diabetic ketoacidosis. So I'm just going to go through just the principles and the targets that one needs to always look for when you're treating diabetic ketoacidosis. So you have to volume replace. So you can use your normal saline or your Ringas. And then you have to replenish your potassium or replace your potassium, continue your IV insulin. And if this pH is less than 6.9, please administer your bicarb. You have to have a blood gas machine because you have to do your ongoing lab monitoring. So every hour you need to look at the status of the metabolic status of this patient. And then while doing this simultaneously, you need to look for the precipitant factors, such as, is this an underlying infection, or is this medication that has gone wrong or prescribed wrong? And then always remember to always put these patients on a VTE prophylaxis. And then, so once you know you've diagnosed, these are your principles of care, you need to have target goals. So you always aim to have a glucose of about 5.6 to 8.3 millimoles per liter. You want to replace potassium up until 5.3. You continuous insulin administration till there is no ketonuria. So you have to always do simultaneously you're doing your blood gas, but also doing your urine dipsticks to look for ketonuria. Only once the HET is less than 11.1, then you can actually replace your normal saline to dextrose solution. And obviously in your obstetric targets, remember we always talk about the baby. You have to avoid steroids because it can precipitate it. And then you can plan your fetal monitoring only once your acute emergency state, the patient is out of an acute emergency state. And once all of this is behind us, then we can discuss about mode of delivery. Okay, so on that, I'm actually concluding my talk. And I want to conclude by saying, or actually leaving you with one of my favorite quotes. It's an African proverb, which says, if you educate a man, you educate an individual. But if you educate a woman, you educate a nation. And I further want to tweak this because if you educate a female, you educate the nation and the next generation. So thank you very much, Nkosi Kakulu.
Thank you so much, Doc, for that informative presentation. I'm now going to move on to one of our very first questions or comments here we have from Nadine. It says, why is prior infant with congenital abnormality considered a risk factor for GDM?
Okay, sure, of course. So thank you very much for that question. So a couple of things. Prior congenital abnormalities are not really very much picked up in our settings. So a lot of patients come to us and say that they've had they have had a baby that passed away from an abnormality, something to do with the heart, we don't know. So for example, if a patient has had a cardiac abnormality and a congenital cardiac abnormality, it can be linked to the amount of glycemic index in that pregnancy. So that is why it is a risk factor. So for example, if your HbA1c is more than 6.5%, it actually tells you that that mother is at higher risk of having congenital abnormalities in their in these babies. So the one that they have is their congenital cardiac abnormalities, and sacral abnormalities are your two major congenital abnormalities that can be missed. I hope that answers your question.
They'll let us know. The next question we have from Nashiba is, do they not use HbA1c test? I think you've talked about this. And because HbA1c looks at the last 60 days in the lifespan of the red blood cells. I think you touched on this one.
I did.
Okay.
So it's because the HbA1c is about 20, so the glucose concentration in a female as opposed to a non-pregnant patient is 20% lower. So HbA1c is not of great value in a pregnancy setting.
So the next question we have is, when should a pregnant person stop doing heavy lifting? So for example, a person that's working as a physiotherapist or an OT doing patient transfers daily. So they gave a very good occupational example of that. So when do we stop the heavy lifting?
Okay, so this has to be always subjective. So you need to look at, it has to be individual based, is what I meant when I said subjective. So for example, if a patient has a prior history of preterm labor or preterm miscarriages, those are patients that we will start from trimester 1, we will advise them not to be lifting anything heavy. So that's patients such as that. Secondly, when we talk about other activities like lifting heavy weights, for example, we normally say the second and third trimester would be a good time. So 28 weeks and above. So that's your going from your second trimester to your third trimester would be ideal in when to stop your heavy lifting.
Our last question that we have here today is, are there any research gaps on diabetes during pregnancy? that emerging researchers can focus on, especially in the realms of prevention and nutrition?
Excuse me, sorry, Mo, can you just repeat
Okay.
that question?
It says, are there any research gaps on diabetes during pregnancy that emerging researchers can focus on, especially in the realms of prevention and nutrition or nutrition?
Of course, there's a lot of research gap in terms of, especially when it comes to nutrition specifically, because I feel, especially in our community, nutrition is so different when it comes to a high earning individual versus a low income earning individual. And if we can actually target specific dietary lifestyles for the low income population to say this is good nutritional value and what is considered good nutritional value to actually decrease your risk of decrease of gestational diabetes later on. I'm not sure if that answers your question.
Okay. Oh, wow. Okay. The comments are coming. Well, the questions are coming in. I've got a hand from Galaxy A71. I'm just going to ask you to unmute yourself.
Okay. I'm Dr. Gertrude Mukelaba Echun from Johannesburg. I just wanted to find out what medications, say antihypertensive medications, are contraindicated in a diabetic woman. Antihypertensives, if they have hypertension as well as diabetes.
Mm-hmm. So most of our antihypertensive medication is we continue these medications in diabetic patients, such as your methyl-dopa, your calcium channel blockers, so that we don't have a lot of antihypertensives, firstly, to work with in pregnancy.
Yeah.
But all of the ones that we do use are actually deemed safe even in diabetic patients. But obviously, you have to think about patients, for example, if they are on 2 agents in your antihypertensive medication and they're still not controlled. So for example, if you want to move from, you've already got your calcium channel blockers and you've already put them on methyl-dopa. Now you want a 3rd agent. One of your 3rd agents would, not ideal, but you can think about putting them on a calcium channel blocker. It's not ideal in hypertensive patients nor in diabetic patients because they have a fetal renal impact on, they have a renal impact on the fetus.
Yeah.
Yeah. So the other medications are deemed safe.
Because what I understand is that the ACE inhibitors, the angiotensin 1 converting enzyme inhibitors, are contraindicated in pregnancy for diabetics, as well as the ARBs.
So those are
what do you say about that?
Of course. So those are also ACE inhibitors. And so these are also drugs that we don't actually prefer giving to in hypertensive patients already. So we should not be actually prescribing these medications to pregnant ladies.
Okay.
Gertrude, are you answered now?
Yes, please. Thank you very much.
All right. Thank you. We have another question. Okay, comment for Lucanio. Oh yes, CGM in GDM. I believe Pooja already touched on that, saying that CGMs actually do have some established research and data to show that they are beneficial and can be used in GDM. I just also wanted to note that, just to say that even in the private industry, CGMs are still quite expensive. I remember the last I saw, we're looking at an average of 60,000, 70,000 per device, even in private. The medical aids themselves have stringent criteria, even for the use of them. We have another question from Prof. Mukanyani that says, would you say an ophthalmic assessment is an absolute necessity, considering that end organ damage, such as diabetic retinopathy, occurs after years of having diabetes?
Thank you very much, Prof, for that question. So we know that with end organ target complications is accelerated in pregnancy. So we always advise our patients, once deemed diabetic, to always have a standard of care. So we have baselines for renal sonars as well as a fundoscopy to just have a baseline before the acceleration and the progress of the disease. So we in our institute do actually ask our patients to go for their fundoscopies as well as their renal scans.
Great, thank you. So I'm just going to, oh, I have another hand. Okay, Nadine. Nadine snuck her hand. You snuck your hand in. Nadine, go ahead. I'm just going to ask you to unmute.
Hi, thanks. Sorry, it was like a last minute question. I wanted to find out with regards to the weight gain categories for obese women. I've seen sometimes that with a couple of my obese patients, they don't even meet the 5 kilograms at the end of the pregnancy, but the baby's still fine. Is it like in terms of growth, like there's no IUGR or anything? Is that acceptable, or should they be meeting the minimum weight gain during the pregnancy or at the end of the pregnancy?
Nadine, can you just, I'm not sure if I got your question. Can you just repeat that, please?
Sure. So I've had a colleague of mine, and with his obese pregnant women, a lot of the times they've been placed on very strict lifestyle changes to prevent gestational diabetes and hypertension, etc. And a lot of the time, these women aren't even meeting the minimum weight gain requirements for the end of pregnancy. So, for example, the 5 kilograms.
Mm-hmm.
If the baby is growing okay, so there's no IUGR,
Mm-hmm.
and the woman is clinically fine, is it okay that she's not meeting the minimum weight gain requirements? Is that still safe if the baby is safe? Or
So thank you. Thanks, Nadine. I think I understand your question. Let me try and explain that to you. So there are two patients that we always need to talk about. So it is a mom as well as the baby. The baby thrives on whatever the environment the baby is given. And another thing is GDM patients are more likely to have macrosomic babies than IUGR babies. And that is actually the pathophysiology of diabetes and gestational diabetes. So if they have pre-gestational diabetes, for example, they're more likely to have vascular problems. And those vascular problems lead to placental insufficiency and then leads to intrauterine growth restriction. So that is the pathophysiology of IUGR in a diabetic patient. Whereas the gestational diabetic patients are not actually exposed to vascular problems. They are more exposed to hyperglycemia. And that short note of hyperglycemia actually leads to macrosomic babies. So irrespective of their glycemic or their weight gain, the baby will actually give you a good, like the babies will continue growing larger than growing as a restricted baby. So it's not, so that's one question, the one part of it. And second, is it safe for a mother to put on more weight than 5 kgs? Ideally not, because they're already, so remember, the more adiposity that you have and you put on in pregnancy, the more risks of end organ damage and cardiovascular risk to the mother later on, even post-delivery. So it's a twofold problem.
Thank you. Sorry, I meant not meeting the minimum requirements. So they don't, we're looking at weight gain at the end. So it's not an issue if they don't gain the minimum of that weight range.
Oh, no, then that's fine because their
fine.
body
Okay.
already has enough storage for that baby to grow. So remember, if you think about it, even in a malnourished patient, you will have babies that are growing. And that actually is because babies actually take nutrition even from the maternal bones. And that is why we actually say that we need an interpregnancy interval of about 2 years between pregnancies, so that the body actually replenishes the nutrition that is lost or given to the other baby for the next baby or the next pregnancy.
That's good. Okay. Wow. Thank you. Thank you very much, Pooja. Everyone is saying what an excellent presentation and an excellent topic that we've had today. It's been one of our most popular topics we've had so far. So I want to say once again, thank you from Clinix for coming out this evening and presenting to all of our attendees. And I want to say to everyone that attended tonight, thank you for joining us. And we will see all of you next week, same time, with a different topic. Thank you so much. Good night.
Thank you very much. Bye.